Dr. Ihekweazu, thank you so much for your time. I know this is a busy time for you.
Great to be on your show.
Now, can you begin by giving us a status report on Lassa Fever, which is the health crisis, if you like, that we're dealing with at the moment? What's the situation there?
So as of the 26th of January, we've had 258 confirmed cases, 41 deaths across Nigeria. This is the time of the year where we generally see an increase in cases of Lassa, but we are seeing more cases than we have ever seen for the same period any time in our history. You know, there are two things really contributing to this. There's definitely something happening and we're seeing more cases, but the other thing that's happened is that we're detecting them better. So, in the past, many Nigerians would die of something that can be described as resistant malaria or malaria and typhoid. We really didn't have the labs and the surveillance systems to detect this disease. So now we're a lot better at detecting it. We're finding a lot more and finding that it's a lot more widespread in Nigeria than we've ever seen before. And that is then guiding the response that we're mounting at the Nigeria Center for Disease Control.
Now, it's good you mentioned the fact that we're seeing more of it and we're dealing with it more efficiently, because the next logical question would be, it seems to reoccur. Year after year, we have Lassa Fever, and some of the material I've seen suggests that this has been happening since the 70s. Why is it reoccurring?
You see, the virus that we're talking about, the Lassa virus, is actually carried by a host animal rat, a specific type of rat. And as long as that rat is ubiquitous in our environment, we will continue to see cases of Lassa. So, it's not surprising you walk across our neighborhoods, you see heaps of rubbish, you see rats in our homes, they come in, and they infect the food. So it's not magic. The rats come into the home, infect the food stuff, we eat them. We don't know, obviously, that the rats have had contact with this food overnight. We consume the same food, we get infected, and then we transfer this infection to others. So this cycle has to be broken. It's much, Ebola is a similar virus, but because there's no animal host in Ebola, or once there's a jump from animals to humans, all the transmission is from humans to humans. So once you break that cycle, that chain, you've cut transmission. For Lassa, it's a little bit more complex because most of the transmissions are from rodents to humans. So there's no single chain of transmission that can be broken. So every year we have to keep reinforcing the same messages around prevention. And that's really the only tool we have at the moment, until we have a vaccine maybe later down the line.
Now, you talked about prevention. I know this may be something that bears repeating, but what are those preventive mechanisms?
So prevention is really based on understanding the life cycle of the virus and that it is passed from rats to humans. And once you really understand this, then you have to start thinking about how to stop that from happening. The first thing is to make your home unattractive for rats. You see, the rats don't like clean environments where there's no refuse, no food lying around, because there's nothing in it for them. So they generally don't come in. That's the first thing, in your gutters, your streets, and around the house. The second thing, if you can't influence that as much as you would like to, is to make sure that the food stuff in your home is then put away from where they can reach. Cover it in plastics and make sure it's out of reach. And I understand that in certain socioeconomic circumstances in our country, this might be difficult to achieve. So we're not going to prescribe everyone putting food in the refrigerator because we recognize that not everyone has one. But this is really, in whatever context Nigerians find themselves in, think about how to make your food, keep it away from rats. Because the challenge is that you cannot know in the morning if a rat has had access to your foodstuff or not. So the best way is to really prevent that from happening.
What would you say to those who suggest the extermination of rats? Something called deratization. I believe that's what it's called.
Yeah, so it's a very interesting term and emotionally appealing. The challenge is that we don't have any tools to do that. What we know about rats is that they're very efficient animals. They reproduce very quickly. If you get rid of it in your compound today, if the streets and the compounds around yours don't do the same, they will repopulate your environment very quickly. So as far as we know, we don't have the tools to do that. So we have to rely on these other measures available to us.
Now, I'm happy you've talked about how this happens. How are people expected to recognize when they have been affected by this?
So this is a very important question. And, if people leave this interview with anything, is to know this, is that we have improved a lot in our ability to make that diagnosis through a laboratory confirmation. Now, the labs that we need to test for Lassa are not easy. There's no rapid diagnostic test kit. So what we really advise is if you have a fever, the first step is to see whether it's caused by the most common cause of fever environment, which is malaria. And they're very easy tests to test for malaria these days. So we're advising Nigerians, stop treating yourselves. Do the test. If it's malaria, oh, well and good, we'll treat you for malaria. But if it's not, it gives us the opportunity to then start looking for other causes. We now have 5 labs in the country from just 2-3 years ago. Every new lab costs about 100 million naira to set up. We have 5 labs that are able to make this diagnosis. We have a system in the country where we can pick up a sample from every state capital to any of our labs. So we have a mechanism through which doctors can call on us, make that diagnosis. Why this is so very important is the earlier you get into clinical care, the higher your chances of survival. And the one area of good news around Lassa is that we've been able to reduce what we call the case fatality ratio, i.e. the number of people that die from the disease from about 25% 3 years ago to closer to 15% today. And that's because of increased and better access to care and treatment, better diagnosis, and really is a group of skilled physicians that are getting better at managing cases of Lassa in our country.
You talked about the fact that sometimes this Lassa fever presents itself, especially initially, by way of symptoms that could be the same symptoms of other ailments, which may not necessarily be Lassa fever. And you talked about the 5 labs now. Where are these labs, and how does one go about the process?
Yeah, so most cases of Lassa present like any febrile illness, right? The whole imagery of bleeding happens in a small proportion of cases and are really close to the end. So most cases will present with fever, weakness, and all the normal other symptoms of a severe malaria episode. So what we've been educating our doctors to do, listen, the most common cause of fever in environment is malaria. So it is good to test for malaria. But if it's not malaria, if your test comes out negative, don't tell the patient the test is not working, or, I don't trust the test, let me keep treating you for weeks, because you're compromising the opportunity that patient needs to survive. So what we have done is work with an innovative Nigerian courier firm that has been trained on how to package these samples and send them. So doctors now know that diagnosis is possible. We've provided a mechanism to send the samples to the lab.
Okay.
Once the sample gets to the lab, we will make this diagnosis in 6 hours. There are 5 labs in Nigeria: Abuja, Lagos, Irua, Abakaliki, and Owo in Ondo State. All of them, we make sure there has not been a stock out of reagents this year. They've all been trained in the same protocols. There's a quality assurance system. So we have done a lot of work. We're not where we want to be, definitely not, but we have grown leaps and bounds from where we were 3 years ago to make sure that we give Nigerians the opportunity to survive this illness.
Now, you talked about the symptoms and how important it is to catch this early so that the chances of survival are much higher. From infection to the stage where you talked about where the bleeding starts to occur, which may then be the situation that creates the panic and, that, look, this is not malaria now. How long?
So it really depends. We're talking about a 1-2 week period, maybe maximum 3, But the point I really want Nigeria, this is not a death sentence. Really, it's not a death sentence. Yes, at the moment, where about 15% of patients will generally still succumb to it. The earlier you get into care, the better your chances are of survival. So be proactive. Doctors too, be proactive, because sometimes you can't blame the patient completely. They do the right thing,
which is to present themselves
themselves to the doctor. But we also, this message really is to our healthcare workers: trust the system. It will work. At least to tell you is this Lassa or is this not, so that you have more confidence in dealing with the patient in front of you.
Now, are medical personnel who treat patients who have Lassa fever susceptible to being infected?
Absolutely, they are at risk, but the issue is that their own risk is reduced to a large extent if they use the universal precautions that we've been advocating. So a few years ago, we had a big cluster of cases of Lassa fever in the Federal Teaching Hospital in Abakaliki. It's now called Alex Ekweme Federal Medical Center, or Teaching Hospital. You know, a week ago, I had a call from the CMD of that teaching hospital. He was sharing with me with pride that he hasn't had a single healthcare worker infection in the last year because they have improved their IPC, infection prevention and control measures. They make sure all their doctors now have gloves to work and have gone through a routine to protect themselves and their patients. So it is possible. And this year, we had an unfortunate cluster of cases in Kano. Right. And I am sure that practice will change. But we don't want every teaching hospital to learn the hard way. We want colleagues to learn from the mistakes of others and not repeat the same mistakes again. Okay. We're really advocating for every teaching hospital to really start putting IPC in their budget line. They must procure gloves, gowns, and all those protective equipment that doctors need to work safely and confidently. And that way, we will prevent healthcare worker infections.
Now, when you talk about things like this, people talk that the vast majority, I mean, if you take the rural areas, for example, the vast majority of those who get infected, even if they have all this information and they're proactive, the first place they're likely to go is the primary healthcare center in their area. And at that point, that's where they come across the doctor. Yeah. How much support have you got for getting this information, this needed information, both about the patients, that is the people, and the medical personnel across to that level of health care as the NCDC?
So, you know, a few years ago, when the federal government decided to set up the Nigeria Center for Disease Control, this is really in realization that there's a unique need for an agency that has the flexibility to deal with these issues, inform Nigerians on what they need to do, and provide evidence and whatever we need to work. But on the other hand, it's a big and complex country, and we're a federal republic. So NCDC cannot really go to every village in Nigeria and make sure they have access to everything they want. So the federal government is really pushing on a concept called primary health care, making sure that we focus on the first point of entry into the health system. The challenge is that every primary health care center in Nigeria is owned by the state, a state government. So we cannot work on our own. We have to work with state governments. And I've really been appealing to governors. Just a few weeks ago, His Excellency, the Vice President, invited me to the National Executive Council meeting, the NEC meeting, to have an opportunity to speak to governors, to really advocate to them to please also invest in health and healthcare and health security. And while it's, you know, there are many needs in our country, we all recognize that. And, you know, everyone wants to build a new flyover and demonstrate big infrastructure projects that they're achieving. And no doubt these are important, but we have to be alive to enjoy all of these. So we're really appealing to all sectors of our governance structure, local government chairmen, governors, not to forget the basics. And all of our citizens, you know, these health centers are in our villages, right? Right. You know, ask about the health center in your village and let's make them functional together. I know we as government have a big responsibility to play, but you know, if anyone in my private circles now ask me what they could do and they want to build a hall or something, I say, you know, don't build a hall. Go and make the health center in your own community that is serving your own people work for them.
Now, I ask that because for many things, for many health issues, what you've pointed to now seems to be where there are challenges. The federal government at this level in Abuja can put in place what is needed for Abuja and maybe the environs. It can advocate, as you point out, at the level of the states and even at the level of the local governments. But when you have emergencies or some level of health challenges like Lassa Fever and even the coronavirus, it would appear as if it's at that level that the most effective kinds of measures can be implemented. And that's why I asked. Which brings me to the next point, which is that as NCDC, the material, of course, also shows that NCDC is, as an agency, new, even though its mandate has been attempted in coverage previously. How has it been? How has that transition gone from an agency now that has this mandate with things like this that create sentiments, sometimes panic? How has that transition been for you and the agency?
So this is such an important question because I think credit must be given to those that preceded my time here and the efforts they had made to set up this center. And I think the heroism around the people that responded to the Ebola outbreak before I joined this organization really brought to the consciousness of Nigerians why it's important to have an agency like this. Now, since then, it's been a bit slower. We've worked very hard to gain the trust of Nigerians. I mean, if you go to the US and you talk about the US Center for Disease Control, there's credit across party lines, across society. Everyone trusts what that agency tells them. And really, that's the model we're aspiring to and working very hard to achieve that. But on the other hand, we've got to put our body where our mouth is. The best time to prepare for a war is not when you're in one. It's before there is one. And it's very hard to focus on an agency like this when there's no crisis. So my general message to everyone, now we're the consciousness of Nigerians. Once the outbreak is over, everyone
goes back to business as usual.
So we've got to really understand that, what we're building here is an insurance policy so that people can go to bed and sleep at night. If you go to the National Reference Lab on the outskirts of Abuja, we have a group of people that work 24/7. They work on weekends, in the evenings. We make sure we get results out on time. We're building a culture that is new because we know that we can't afford to fail if there's a crisis. So we really need the support of everyone to join us on this journey as we build a credible agency to protect the health of all Nigerians.
To take that further, what is your core mandate?
Our core mandate is to prevent, detect, and respond to infectious disease threats. So really, you can think about this in terms of health security. The health security of Nigerians. We often battle adversaries that we know and we can see. The viruses and bacteria that we fight, we can't see them, but they're there with us. They can multiply very quickly. They can cause a lot of harm very quickly. So it's not something you can fight with bricks and mortars. It's something that you fight with science, with knowledge, and expertise and delivery.
How much support have you gotten in terms of this work? Because a great deal of this work is, of course, in the research of these things and latest practices. And how much support have you gotten from the educational institutions to start off with, where the doctors and other such medical personnel who would have, some of them at least, would eventually become staff of your agency or related agencies? How much support have you gotten from them? What has been the interaction like?
Yeah, it's a journey. The biggest supporter really of the work we've done has been in the leadership of the ministry. So the minister and his team really recognizes the work that we do. We've been included in something called the Basic Healthcare Provision Fund, which funds medical emergencies, and there's a recognition that public health emergencies are just as important as any other medical emergency. I think where we struggle a little bit is really the point you made on our educational institutions. The science behind the work we do is a very rapidly evolving one, especially in the laboratory medicine side. So we find that, when we do employ graduates to start work with us, we really have to start from the beginning to train them. So, but I see this as an opportunity rather than a threat. We are training a whole group of scientists that will grow in their work, and their outputs will define the work that we do for many years to come. But the challenge we have is there's no quick way to do this. To learn and to become an expert in epidemiology, in virology, in microbiology, you need time, you need to be mentored, you need to work on this. So we will stay on this ball, and my prayer is that the work that we've started is allowed to grow and blossom. We work with colleagues across Africa, the Africa CDC, the World Health Organization, sister public health agencies. And with time, we will have a fantastic institution if we let it grow and nurture it to the state that we want it to become.
Part of the reason why I asked that is that I know that before you came to this, you had worked in, amongst other places, South Africa. And you had also worked in other places even outside of Africa, the UK, for example. And with that kind of background, with that kind of experience, coming to our own system, which is for all practical purposes fairly basic, there's no doubt that you would face some, not just initial, but ongoing challenges with, I've talked about the educational institutions and personnel. But even beyond that, talking about the understanding of the link between the work that you've been asked to do and what eventually is the work that other institutions in the health sector and even outside the health sector have to do, but how that links up with your own work. How much success have you had with that, especially when you take it in comparison with, say, in order not to make a comparison outside of Africa, say, South Africa?
So I think the first thing to say is, no matter what experience and opportunity that we've had to work abroad, it's always a privilege to serve. To be picked out among 200 million Nigerians and say, listen, lead this organization is a privilege, and one we have to take very, very seriously, and I do so. In terms of how we translate this to products and science and progress, is it's a harder journey, but a necessary one. You see, there's a general thinking that civil servants in Nigeria are lazy, unproductive, and really don't care. To be honest, it hasn't been my experience in NCDC. I think Nigerians sometimes are waiting to be activated, but when you manage to activate them, they can really go over and beyond the call of duty. So I think we've created a culture here where people are really doing their best. The challenges are difficult, but it has been a very fulfilling experience for me personally to see people grow, to take responsibility for areas of work, deliver on it, aspire to new heights, and then own their results, own their success, and then share that with others. So yes, you may not have all the comforts of a perfect scientific environment to thrive, but I think there's a bigger opportunity to make progress and to make a difference in Nigeria. The challenge we have with Lassa and its treatment is about, to an extent, scale. As much as we're diagnosing more, we're still talking about 1,000, a bit more confirmed cases a year max. So there's not enough demand for large-scale production for the ribavirin. Yeah. Okay. So it's a tricky environment, but I'll take the question a little bit broader. Right. I think as we improve our diagnosis, and this is really a black box in Nigeria, our laboratory medicine has stayed in the dark ages for many years. It's now coming out of it. You see new laboratory chains opening in the big cities. The smaller ones, it will take a little bit more time. But, the whole diagnosis of malaria and typhoid, there's nothing like that. There's a whole area that needs to open up a lot more. And once people start actually having the tools to diagnose what is wrong with people, it will change the entire treatment landscape in Nigeria.
Now, let me switch you to something else that is an emergency, even though Nigeria is not yet at it, and that is the coronavirus. And in this regard, I want you to use this opportunity to disabuse the minds of the people on a number of myths that have, if indeed they are myths, of course, that are spreading. One, where are we with that in terms of cases? I know that you had to deny that there was already a case in Nigeria at a point. But what are we doing about that as a health mechanism to prevent it? Because already, even in the run-up to this interview, between when it was scheduled and my arrival here, there have been new cases reported in new countries. So it is spreading. What do you think we are doing, and are we doing it right?
So I think really this is where the fact that this type of organization exists is critical, because we're focused on things like this all the time. We have links to sister partner organizations across the world doing the same work that we're doing. So since it broke early in the year of this new virus, the first thing you do when there's a new virus is try and learn as quickly as possible about it. And then the containment principles are always the same. You try as hard as you can to contain it wherever it has emerged from. So these two strands of activities have been going on in parallel. Containment at source and learning as quickly as possible on the new virus. So we do this every day. So we have a coronavirus preparedness group that has been working on all aspects of the response. Just last Saturday, for the first time, we're able to confirm ability to make the diagnosis in Nigeria. I think we're only the third African country to do so. And that means if there's a suspect case today that fits the case definition, we're able to say, yes, this is a case. If it's a case, this is what needs to be done. So there are a lot of aspects of this, and we live in an interesting time. There's never been a time like this. The demand for information is almost real time. You've got to respond to media, political leadership, but we have to also do the science and make sure that we have the answers to provide. So yes, over the weekend there was a case, and we didn't deny it. What we did was confirm that this was an individual with symptoms. In the end, it turned out that that individual, yes, returned from China, but actually had no symptoms. Someone just went overboard and got added 1 + 1 to get to 5. And then we've had a lot of cases like this where resources are taken away from the work that has to be done to go and investigate hoaxes and things. But in the middle of all of that, there might be a real case. So what we've done is prepare ourselves to make that diagnosis and make sure if there is a diagnosis, we can establish a response.
What are people to do in that case? Because I don't know if that's a bigger issue than Lassa Fever, but I know that what are people to do? I mean, people listening to you now would ask, if I see someone, yes, it emanated from China, but because now it's in so many other places, if I see someone what am I looking out for? Even including law enforcement agencies at the ports, what are they supposed to be looking out for that could make someone more of the case definition that you mentioned earlier?
Yeah, so I think at this stage, we haven't found any case in Nigeria, so it's not circulating here yet. So our objective is to prevent its entry, and if it does enter, make sure we are able to detect as quickly as possible. So the first line of defense is really at the points of entry, at least at the airports, where you have thermal cameras. If it does pick you up at the moment to have a fever, you will be asked other questions about your travel history. And the key thing is to establish if you've been to China, mainland China, in the last 14 days. Now, it is also possible that you might be infected, you don't have a fever yet, so you come in without a fever, and you develop a fever the day after or 2 days after, right? Because every illness has an incubation period. then if you do present to a healthcare worker, the advice at the moment is, the key thing is, have you been to China in the last 14 days? At least for now. And once that is established and you contact NCDC, we will send a team to collect a sample from you and get that sample to the lab. So that's early detection.
Right.
But the final thing is, even if there was a case and it missed the
point
the
of entry,
and
yes,
we found that there's still an opportunity to contain it within whoever has it in its family. So the key thing is for Nigerians to trust the system. We've put out a toll-free line all over. It's on our website. We're asking people, if you have come back from China, and this is not just for the Chinese people. Lots of Nigerians travel to China. If you have come back from China and you have symptoms, please let us know. There are a series of steps. It won't cause you any harm. We'll make sure we respect your confidentiality and your environment. We do it in a discreet way. Take a sample, at least let you know, do you have this illness or not?
Now, what role does self-quarantine play in this?
Yeah, so this has been a big issue, and we've been careful to say that it's important. This we've seen is a very transmissible virus. The hospital is the worst place to have a new virus because it's a point of amplification. You have a lot of patients that are already weak or ill. We don't want them getting infected. So what we have said is, if you're ill, call us. We'll actually come to your home and take a sample, so you don't spread to others. So there's no big issue. The issue is really, we want to prevent spreading of this virus to others if we can help it. So unlike most other things where we say go to a hospital, we're asking you, please just stay at home. Let's come to you, take a sample, confirm that this is what you have, and then support your care and treatment.
Now, those who have, in this particular instance, succumbed to coronavirus, seem to have a particular set of case types, so to say. What are these? And therefore, who is particularly susceptible?
So I think there's a key question. The important thing with corona, as far as we know at the moment, right, only 2 in 100 cases actually succumb to this virus. So 98 out of every 100 cases will survive. Many of them have a mild illness, actually. The most vulnerable are people with some underlying medical illness that are already frail and then get this virus on top of what they have had already, or sometimes elderly people. And so that's one reason we want to keep it out of hospitals as well. So I think as much as there's been a lot of anxiety around corona, this is not Ebola. By any stretch of imagination, right? We're still looking and learning how this will go. But at the moment, there are 2 things for every new disease: how quickly it spreads, we call that transmissibility, and how quickly it leads to death, we call that virulence. And around these 2 indicators, this really is at the lower end of both of them. The issue, it's a new virus. Everyone is a little bit agitated. But it's definitely not the end of the world.
Now, when people talk about, declare this a public health emergency, what does that mean? And how does that help in this process you've just described? Not just for corona, for any kind of epidemic or breakout of this kind of thing.
So there are few specific guidelines around the World Health Organization called the International Health Regulations. These are regulations that we have all agreed to uphold. And what it then does is WHO is able to mobilize resources from countries and coordinate the response a lot more. And so that is really what it means. And then in certain circumstances, it will recommend trade and travel restrictions, which it hasn't in this case. Why it's so important to share information is everything we're doing based on what we have learned. A lot of it has come out of information from China. We got to know the genetic sequence for this virus less than a week after, the fastest that has ever come out for any disease, any time in history. China has lately been very proactive in sharing information. And global health security depends on countries sharing information. If we get to the stage where countries close up their borders and stop communicating with others, we will not know what is happening, and the risk for all of us will increase. So the need for coordination is critical, and that's why WHO at this stage, because of transmission in a few countries, declared it a public health emergency. So globally, we can mount a coordinated response against it.
So it doesn't confer any particular advantage on agencies like yours in the process of containment. I mean, not just of coronavirus. I mean, if, for example, the federal government were to declare a public health emergency over Lassa fever, what would you be doing differently from what you are doing now that it hasn't been declared as such?
The specific, at the national level, the specific responses will depend on the disease. So, Lassa and its implications are different from a respiratory virus like corona. So the measures will be different. But what it really means is that once you declare a public health emergency, in public health, we're very consultative. We do meetings and all. Once you go to a public health emergency, you fold into a command and control structure. So we set up an EOC. There's an incident commander. He then takes the lead of actions, the timelines, and deliverables. So our whole mode of working changes from a slow consultative approach to a command and control style approach, which we learned from the military, which then helps us in coordinating the response across the country.
Yes, Lassa fever may be creating some level of attention and anxiety. Maybe some will even say panic at this point. Coronavirus internationally as well. But if we say in Nigeria, there are other diseases that also show up from time to time and which also fall under your purview. How are you dealing with those at the moment?
So, you see...
I've not mentioned any in particular, so I'm asking a general question.
I can mention some.
Right.
Our primary focus is always on the set of diseases we call epidemic-prone diseases, because of the disruption they cause to society when outbreaks do happen. A subset of those are called vaccine-preventable diseases. And that's really where we really call on all Nigerians. If you take your children to get the vaccines that are part of their routine immunization schedule, that are actually free, at least to the point of care. It's not free for the country. We have to buy the vaccines with our partners, right? But it's free for you taking your child. But you still see many Nigerians not taking their children to be immunized. And the next thing, they're having measles, yellow fever. All these are vaccine-preventable diseases. There's no reason why a Nigerian child should be having measles today. The other disease we have a challenge with, and it's also very painful, is cholera. Cholera is one of the oldest infectious diseases we know of. The prevention is very simple. If you are drinking clean water, boiled water, or tap-on water, you will not get cholera. Yeah, but there was a time where delivering water to people used to be a big campaign issue, but it's disappeared. Everyone is solving his own water problems. But
there are people who still don't have access.
They have been left behind, and that is my point, is that the Nigerian elite need to recognize that because you can have a borehole in your house and solve your own problems, doesn't mean that your family and everyone that's still relying on water from the stream, that upstream someone might have defecated into, and you're fetching downstream and end up with cholera. So we've got to refocus on some of these diseases for which there are simple solutions, so that we can focus ourselves on the harder ones like corona, Lassa, and monkeypox.
Now, the other thing is that if you take, for example, a disease like leprosy, just a couple of hours ago, I was reading that the Bauchi State government admitted that there were 81 people who have been reported as having leprosy. Now, the link between that and the stigmatization, which prevents people from reporting early things that might have allowed medical practitioners like yourself to quickly know what's going on before it becomes a real crisis, is still a problem. And therefore, is it a problem of awareness or is it more of attitude?
I think it's both. We have this thing with infectious diseases, and whether it's leprosy that you mentioned, or HIV that is sexually transmitted, or TB that is seen as a disease of poverty, we have to all realize that these are infectious diseases, and there are solutions to most of them. By stigmatizing people that have this, we make it worse for them, worse for society, worse for doctors providing care, worse for their families sometimes. So the thing really is to treat this as not something that you should stigmatize anybody about, and really focus on the problem. And once you focus on the problem, you find that many times there are solutions to them.
Now, I've spent a lot of time on the current situation and so on. But now, as we wind this down, I want you to also take a look ahead.
Yeah.
Because there's a great deal of attention on your agency, there's a great deal of attention on these issues, because we have two ongoing
Public health
emergencies, one local, one international. It would appear, as it has been in the past, that once the situation stabilizes or normalizes, it's back to business as usual for the health sector, for the victims or those who survive, and so on. So the question then is, looking ahead or taking a frontal view now, how does one prevent us from having this kind of conversation, say, a year from now?
Yeah, so I think that I'll answer that question in three parts, right? Firstly, from the part of government,
right.
My leaders and my employers, we really need sustainable, substantial, and stable funding for the Nigeria Center for Disease Control.
Right.
This is something, no political leader ever wins an election on an outbreak that has been prevented, right? But this can disrupt whatever agenda you have for the people. So it's important that we continue, and this government has done so, continue investing in building up this agency, enabling us recruit the people that we need, buy the equipment that we need, and grow the work that we're doing across the country. The other is directed at healthcare professionals. There are things, the world has changed. Everybody, whether you're a surgeon, an ophthalmologist, a dentist, you have to focus on infection prevention and control. So you have to use universal precautions. If your CMD in your hospital is not providing you with gloves, please make sure you're putting pressure on him every day to do so that we can practice safely. My final point is to Nigerians. There's often the feeling that a government will solve all problems. But we have a responsibility ourselves to do the simple things, to keep our environment clean, free from rats, to immunize our children, to make sure we boil water before we drink. So there are lots that we can do ourselves. We can mobilize. I see Nigerians going home to their homes, and just in front of your house, there's a heap of refuse, and you step over it and pretend that you don't see it. You're not doing yourself any favors. It's like sticking your head like a giraffe in the sand. So every Nigerian can come together. Let's all become surveillance officers, public health people, educate ourselves, and make sure we keep ourselves free from infectious diseases.
Now, finally, on a personal note, I alluded to it earlier in the interview when I talked about, your experience, the background from which you come. Many, not necessarily healthcare professionals, but people in your position leave, and you've talked about the fact that you consider it a privilege to come home and share what you've learned elsewhere. Now, when you take a look at it, on the whole, and with others who look at things like this, do you see cause for optimism going forward, especially now that you're fully aware of some of the really almost debilitating challenges that people in your position encounter? Not just in the health sector, right across all the health sectors, people who have practiced in the places where best practice is second nature and so on. And then they have to come to what some of my colleagues have called the jungle here. And then I have to practice here and try to implement those best practices here. Do you see hope, optimism, cause for both?
So, Paul, the simple answer is I do. And the reasons are this. You're right, I have worked in a few settings around the world. But there's no place I have seen the energy and enthusiasm of people to work and to deliver than in Nigeria. I think, in a way, we do ourselves a disservice by setting the bar mentally for ourselves very low and having low expectations of ourselves and socializing the concept of let's manage it like that. My experience here has been really if we push ourselves, we can do a lot more, and that's been my experience. But on a personal level, living like many of us with a family growing up, developing my own kids growing up, I couldn't imagine facing them in a few years' time and reflecting on Nigeria and having them ask me the question, so Daddy, what did you do? Why did our country, our society end up this way? So, and this is not really about me. This is really to encourage anyone working this program in Nigeria or abroad. Our problems will not solve themselves. We all have to get involved. And by the little progress we've made in the Nigeria Center for Disease Control, it has shown that it is possible. So if we just put the same energy into all our other problems, I'm sure we'll have a great country that we can all be proud of.
Dr. Ihekweazu, thank you so much for your time. It's been a pleasure. Thank you very much. That's today's episode of Newsnight. Thanks for watching. Do let us know what you think of the conversation. The handles are right there on your screen. Goodbye.